So you've got an insignificant cancer.
Yep.
We just did the 12 needles,
Yes.
which sounds horrific
Yep.
as a man. So we've just done the 12 needle test. One of the needles we get back says I've got cancer.
Yep.
Welcome to the Coleman Group podcast. Today I'm excited to have Dr. Busch, who has over 40 years in diagnostic radiology and hundreds of international research studies to add to the Busch Center here in Alpharetta, Georgia. Today our goal is to change the way you feel about prostates. We want to completely turn the way that we do it here in America upside down, on its head. And I'm also joined with Dr. Barentsz, who is a leading expert and professor as it relates to the prostate. And so excited to have Dr. Busch here, right here in Alpharetta, Georgia. We have some of the leading technologies and imaging right here for your prostate. He runs a gentleman's center for men. And I think it's just absolutely wonderful to have you guys on the show. So, Dr. Busch, please introduce yourself, and also please introduce our guest, Dr. Barentsz.
Yeah, I am Dr. Jelle Busch, who is the managing partner of the Busch Center. That name was not chosen by me. It was chosen by people who said my name is known from East Coast to West Coast for prostate expertise. So we accepted that name. But this all started over 11 years ago when I met the gentleman who's across the table from me, who is Professor Jelle Barentsz from Nijmegen, Holland, in the Netherlands on the Waal River. Beautiful little town. And I actually ended up spending 6 individual weeks training with him on learning how to do prostates, how to image prostates. And then what happened is we were finding cancers that nobody else could find, so I had to go back, and he had to teach me how to put a needle into a cancer in the magnet, which is very unusual, and there's not a lot of people in the world that do this.
Very interesting.
And so Professor Barentsz, in my opinion, is the world authority on prostate imaging for prostate cancer and its associated diseases. And also, very importantly, he takes the lead in what is becoming a international guidelines and acceptance on how we report, how we perform, and how we teach this technology, because it is very complicated. And it takes a dedicated physician to want to dig into this. But I know Professor Barentsz, he spent his whole life, professional life, dedicated to this. And what's so interesting to me is 11 years ago, I knew he was right. But now there have been many, many papers that he has authored and edited and helped with that have proven he was right, beyond a doubt, and also as evidence-based medicine, which has now been accepted in the European guidelines.
Wow. So, Professor Dr. Barentsz, please tell me how you're changing the way that we view prostate exams.
Well, I was thinking about the parallel between prostate cancer and breast cancer. And all I did with prostate cancer is nothing smart, nothing new. I just copied and pasted it. And what I learned is that when a woman has a lump in her breast, and when she's uncertain about it, you can imagine that when you feel something which wasn't there, you're fearful for cancer. What do? What's the first step you do? You go to a radiologist, he makes a mammogram, and based on that mammogram, there will be a biopsy. And that will tell you, within one day, it's good or it's bad. So when it's good, it's nice. Your fear has gone away. You go home happily. But now let's assume that you have a lump in your breast and the doctor puts on a blindfold. He takes the needle and he wants to stick the needle into the tumor. What will that woman do? She will go away and will come back with her lawyer.
Mm-hmm.
Blind biopsy is not done in breast. However, if you are a patient with an elevated PSA, that means you have a suspicion for prostate cancer.
Mm-hmm.
You go to the urologist and the urologist said, I will put in 12 needles in your anus. Okay, 12 needles. Yes, when can I do it? Those needles are inserted blindly.
Mm.
That is the current practice of prostate cancer diagnosis today in the United States. Is that bad? Yes, of course it is. Can the urologist be blamed? No, because this is the way we were educated in the medical world. We didn't have something new. Well, 10 years ago when Joe and I met, MRI was developing. And it was a mess. It was a complete mess. So I thought, well, let's make a standardization. Let's standardize the way in how you look at the images. And that's called PI-RADS. And it's nothing smart. I just copied it from BI-RADS from the breast. And now every radiologist and urologist in the world is reading prostate in the same way. So we talk about the same thing. The second step is acceptance, and that in the medical world is very difficult because we medical doctors, we are very conservative.
Mm-hmm.
Not Dr. Busch and I, we are not conservative. We think out of the box. A lot of people don't like us for that, but the persons who do like it are patients. So, we said something needs to change, and we proved to the urologist, the medical world, the conservative medical world, that MRI is better. Well, of course it is, but you need to prove it, and the proof is there. And the reason that I'm here is that I'm telling Joe and telling the people here around that the guidelines in my country will change next week. That means next week, no biopsy, but an MRI first. When a man has a suspicion for prostate cancer, you need to do a good MRI. So, my motto is, better a pretty picture than a painful puncture. What does it mean? You need to make a good MRI. What does it mean to the patient? And I would like to show you some data because Joe and I, we started already early in adopting MRI, and I would like to show you some data of the last few years in my expert center, which are similar to the results Joe has. So if we can see this table, I'm talking about more than 3,000 patients who all had a suspicion for prostate cancer. They all had an MRI. And if the MRI was normal, the patients did not have a biopsy. And you can see here that with the blind biopsy method, the current standard of biopsy in the United States, so without MRI, you have to biopsy all men. Whereas if you look at the newest data, you only have to biopsy 43% of men. 57, almost 60% of men don't need 12 needles. What does it mean? You're concerned, your PSA goes up. And you go now to Dr. Busch and he makes an MRI.
Mm-hmm.
The moment he tells you it's normal, fear is gone away, you don't have cancer. Because you see on the MRI why your PSA, why there is a suspicion, is elevated, why you have a suspicion of prostate cancer. It's either a benign enlargement or inflammation. That's what you see on the MRI. So, MR, normal, go home, be happy. Test your PSA 1 year later, and then if it's similar, no cancer. If you have cancer, and you can see here that if you have cancer, you need to do a biopsy in all those men. And only 8% of men have a biopsy which is normal, versus all men with the current standard. So it's an enormous difference. Now, in 35% of men, we find cancer. And you can see that if you use the thrust biopsy method, that means the needle, the blind needle method, you say, oh, my Professor Barentsz, you're completely wrong. 48% have cancer, and you only detect 35%. What's going on over here? Well, there is a very difficult story. We as medical doctors, we sometimes make something very complicated for the patient. There are cancers which are harmless. They are sleeping cancers, and they won't wake up until you die. So that cancer won't harm you. Nonetheless, if you poke in needles in your prostate, you will find quite a number of those cancers. 25%. So 1 out of 4 men with elevated PSA will have an insignificant cancer being detected. But if I tell you, you have an insignificant cancer, then you ask yourself, hey, cancer, when will you wake up? Isn't it better to separate? So, before you know, your prostate is in the bucket.
So on the needle, so that's interesting. So you've got an insignificant cancer.
Yep.
We just did the 12 needles,
yes,
which sounds horrific,
yep,
as a man. So we've just done the 12 needle test. One of the needles we get back says I've got cancer.
Yep.
Okay. At that point, we don't know if it's insignificant or not. Is that correct? From the needle test?
No, from the needle test, you know whether it's significant or not. Let's look again at the data.
Okay.
So in 48% we detect cancer. In 25% it's insignificant, so it's harmless. And in 23% it is significant. Those are the bad guys you need to treat.
Mm-hmm.
If you look at the MR method, you see that we only detect insignificant cancer in 9%. So that's a reduction of 16%.
So on the 16, though, what would be the normal practice in America? So on the original 23%, if I don't know whether it's insignificant or not, what's the next step for the man?
Well, you know that it is insignificant. That's the diagnosis you get. 25% of the men will have the diagnosis insignificant cancer.
Okay.
So don't do anything. That's the best thing you can do. The best thing you can know is nothing. If you have an insignificant cancer, you should not know, because it is not in any way harmful to you.
Okay.
Unless you know that you have it. Then you know, I have insignificant cancer. I remember the word cancer. So, whereas in 23%, you do have a significant cancer detected. Now, with MRI, it's 9%. So, it's an enormous reduction of the number of insignificant cancers. So, they're not detected. We can just put the threshold of detecting cancer in that way that we will miss the insignificant cancers and that we will detect the significant cancers.
Okay.
So, we will detect the 26% significant cancers. That's even more than what you detect with biopsy, 23%. So, to summarize, MRI offers in 60% to patients the advantage, no biopsy. Go home, be happy. In 16% of patients, it reduces the number, it's a reduction of number of insignificant cancers detected. And finally, it slightly increases the number of significant cancers detected. What does it mean to the complication rate? The complication rate is a factor 10 lower, 0.3% instead of 3%. Then finally, what about cost? What's your first idea about MRI? Expensive or not?
Sounds expensive.
It sounds expensive. You phrase it very correctly. It sounds expensive, but it is not expensive. It is cost effective. Why? Perhaps Dr. Busch, you can explain why it is cost effective. Why is MRI not very expensive? Can you explain that to me? We did a study. It saves in the Netherlands. It saves at least $400 per patient, and we talk about in the US about 1 million patients with a suspicion of prostate cancer. So it's 1 million times €400. That's a lot of money. So Joe, can you explain why is MRI cheap?
Well, it's because
It's your center.
you need to think about what really happens to people that have jobs and what's going on in the world today. So first of all, your primary physician sees that you have an elevated PSA. Of course, you've taken the day off to go to your doctor or half a day. And like all doctors, you got to wait forever. And so what they do is they send you to the urologist. And of course, the urologist is going to see you and explain to you that you have an elevated PSA, and he's going to schedule you for this random biopsy. That is standard of care in America. He's just following his guidelines. So the patient leaves. Very frequently, they're not told of all the true complications of doing this, which can be pretty gruesome. You can die from a 12-needle random biopsy from sepsis. Yeah, it's not so much a problem in this country, but it is in other countries. And then you come back, you have your biopsy, and of course, with 12 needles, you're going to have usually quite a few symptoms and probably lose another fourth day of work the day after. You're not going to be in a mood to go work or perform your usual job. Now, the other thing that's very interesting.
May I just interrupt you, Joe? I'm just fascinated about the economic effect on profession. So
yes,
we haven't calculated that amount of money within the calculation I mentioned, but can you tell me for example, what does it mean to a pilot who has his PSA check and then has had his biopsy? Is he allowed to fly after biopsy?
If he has a diagnosis of cancer, he's not allowed to fly.
But even after biopsy, when you have a risk of 3% of having hemorrhage or fever,
he wouldn't go back in the airplane that day.
No,
sure.
so
or not, maybe even probably not even the next day.
Because what are the talk? Just kind of for someone like me that doesn't have a medical
and it's
background.
bigger than that when you're comparing it to my site. In other words, since I'm a non-insurance model and operate only on cash, we're able to do your scan in the morning and biopsy you that afternoon, and we'll have the results the next day. And actually, if I see advanced disease when I'm doing your scan, I can actually scan your entire body and stage you. I can actually stage the patient all in one day. That's impossible in America under the insurance model because in the field of radiology in America, we have what are called radiology benefit managers, RBMs. And anytime you're doing any type of imaging procedure, that has to be cleared by the RBM. And even if the RBM approves it, you may not get paid for your study. There's another huge issue going on. The type of procedure I do with the expensive titanium needle costing nearly $400, Medicare will not reimburse you for that. So to be blunt with you, every time we do a Medicare inboard targeted biopsy, we don't even break even.
Wow.
And that's how bad it is when you hear these politicians talking about, Medicare for all. It doesn't work. I mean, you would go out of business. But at the same time, what we were talking about, there's a bigger picture here than just the actual cost per procedure and per move.
Right.
For instance, I don't want to get into this now unless we have time, but the fusion biopsy, which my experience with it, they're all performed in a hospital. So imagine what it's like to walk into a hospital and the production and the hallways you have to go to. Matter of fact, it's very much like I was against mammography, just as Dr. Barentsz was pointing out. You don't want the mammogram machine buried in the bowels of the hospital. You want it out on the sidewalk, on a nice, pleasant center with a fountain and calming atmosphere, and you don't have to wander through the bowels trying to figure out where I'm going to get this biopsy. Imagine the anxiety of you having to have a prostate biopsy. And you wander through the bowels of the hospital, and then they get you ready in the pre-op, and then you have the op, and then you have the post-op. I mean, it can be I've seen it. It's a major production and a major cost.
Coming back to money, so the pilots who have a negative MRI can fly back home the same day.
Yeah.
They can even take their job going back to the airport from Atlanta and fly professionally back, because the only thing that happened was an MRI, and they go home, they're happy, they don't have anything. With a biopsy, they would have been a passenger in the plane and not the pilot in the plane. So that saves a lot of money. But the most money is being saved by unnecessary surgery.
Yeah.
When
We didn't
you
get
do
into that.
surgery on the 16% more insignificant cancers, that's costing a lot of money.
Mm-hmm.
And it's also causing complications.
And radiation.
Impotence, incontinence. So whether you do prostatectomy or radiotherapy, it costs an enormous amount of money, which is unnecessary. Insignificant
For-
cancer should not be treated.
That-
And 16% of procedures which are 1,000-fold more expensive than MRI, that's a cost saving. And that's why this model is good. And that is why MRI is cheap. When I took up my professorship in the Netherlands 20 years ago, I was an early addict to MRI. I said MRI will make healthcare cheaper. And nobody believed me. I was even on the radio. Hey, professor, how can you say that it's cheaper, such an expensive machine? Well, think about cost effectiveness. Saving money in treatment. You need to start with a good diagnosis. That's exactly what Joe is doing. He is an expert in the US. He was trained by me. It's just the other way around. The young guy trains the older guy. And we found each other. It was fantastic. And he took over many things. And he's the top expert in the world. He's a little bit modest with that, but I can say that he is the top expert in the world, period.
So you're saying that there are folks that have had their prostate removed unnecessarily
Yes.
because of the current
Yes.
way that
And they've
we-
had their
Yes.
prostate
Yes.
irradiated unnecessarily
Yes.
with seeds and external beam and all. You see, we've learned a lot in the last 10 years. We're now looking at the gene profile of the cancer, prostate cancer cells themselves.
Okay.
We call this genomics. And we're learning that these cancers that Dr. Barentsz was talking about, these indolent, these unnecessary cancers, we have no proof that they've ever metastasized and killed. There is no academic proof. And we look backwards on all these people, and I'm telling you, we've seen close to 30,000 men with their prostates removed that
You should be mild on the urologist because the diagnosis of cancer is there. The pathologists now are even thinking about not mentioning these insignificant cancers. It's just, you should call it perhaps an aggressive inflammatory process instead of insignificant cancer. That's the difference.
And
With breast cancer, it's exactly the same. You have also there the problem of indolent, insignificant cancers.
And imagine when we were talking about these blind biopsies, so you really don't know what your gland looks like. But say most glands are about 40 millimeters or 50, 60 millimeters. And the blind biopsy out of the 12 needles, you have 1 millimeter of cancer. That's what we see. But they tell the patient that word. And think about that: 1 millimeter out in a 50 millimeter field. I mean, is that really a significant cancer? I mean, and of course at the time, we all thought it was significant. I mean, it was cancer. You take it out. I mean, so we've learned a lot, and I think we're going to learn a lot more. Would you not agree, Dr. Barentsz?
Yes.
That and these targeted biopsies we're now doing in the magnet, we're learning that these cancers, it's not a cancer like you think. It's the same little round ball of the same lesion. It's actually made up of different kinds of cancers. Well, the MRI has the ability to find the worst part of the cancer.
Oh, wow.
So when we do the biopsy, we biopsy. Dr. Barentsz taught me that you biopsy the worst part of the cancer. You don't just stick what you see.
The most rotten place in the apple.
Yeah.
That's what you need to get out, because that is determining the prognosis of the patient.
So with the blind test, could it be possible that they detect cancer that it's not even in the prostate? In other words, are they moving around other parts?
No.
I mean, they know that it's in the prostate.
They are not that blind. They have ultrasound, and ultrasound shows where the prostate is, but you cannot recognize as well as with MRI whether there is a cancer present.
Okay. Yeah.
It probably misses somewhere in the neighborhood of 50 to 60% of the cancers they can't see.
Certain areas in the front of the prostate those are areas which are very difficult to detect tumors with ultrasound. So,
long story short, this is a complicated process. It's not. I'll never forget that coming back with Dr. Barentsz my first visit. I thought, like I said, this is really complex. It is not what people think it is.
Now, we should end every story with a nice message and a nice thing. I'm happy that we made a change in Europe, and I'm sure that the change will be made in the US in 1 or 2 years. I think it will be pretty fast. Tomorrow I will fly to Denver to teach MRI with a urology group, and I try to convince them that MRI is a good way to go for. If you look at the papers in Europe, in the urology journals, they are really in favor for MRI, but they are concerned. Their concern is the capacity and the quality of MRI. You need to have a pretty picture, and not any picture, instead of a painful puncture. And the good thing is that Joe Busch tries to be the example how you make the pretty picture and how you make this possible. With his magnet, he will be able to do 3,000 to 4,000 prostates every year. And if there are more, he will buy a second magnet. So he will be an important example to other radiologists, and I think that's the way to spread the message. You need to be an example. You need to be the first. And he's very successful, and I can just advise any man with a problem with prostate, make an MRI, and for an MRI you go to Joe. Period.
No, it makes all the sense in the world. I mean, I would certainly rather have one MRI with a clear picture than 12 punctures with a guess.
I would like to make another statement, a joke which I always presented at presentations. You know, the urologist is feeling the tumor with his finger. And what I always say, the finger of the urologist doesn't have eyes, but we have MRIs. And with that, I thank you very much for the opportunity to spread my message. I have a very nice disciple, Joe Busch.
Yes.
He happens to be a little bit older again than I am, but, well, he cannot be blamed for that.
Well, thank you both for joining the show, and it is truly cutting edge what you guys are doing. And thanks for stepping out and changing the world view on prostates.
Thank you.
Both.
Thank you.
Thank you.